Hello and welcome to episode 4 of New Nurse IRL. Today we're going to be talking about rapid response. So what is rapid response? Well, from the words of my husband, it's something you call when you need a response rapidly. And it's true, he's not wrong. Let's say there's some emergent situation that's going on where you need a provider's order stat, because if you don't get people in there right away, your patient can deteriorate quickly, which can lead to further issues. So this also depends on your hospital and the unit that you're working in. So a lot of the times in intensive care unit, they don't really call rapid response because they're the rapid response team, and normally there's a nurse practitioner or a PA or a doctor that's there to give them orders right away, because their patients can deteriorate quickly to begin with because they're more intensive. So there's also rapid response teams in certain hospitals that when you call a rapid response, they're assigned that day to come to whoever calls that day, and everybody basically has an assigned role already. So I normally get a lot of questions, but the top 3 normally are: when do I call a rapid response, what to do during a rapid response, and how do I handle it, especially if it's my first one. So I made this nice little mnemonic to help you think. I called it BARD. So it's basically breathe, assess, review, and decide. So I think just like my other videos, the easiest way for me to explain things is through example. So I'm gonna give you a few examples, okay? So if you just ask me generic things like, oh, do I call rapid response if my patient's having chest pain, shortness of breath, a seizure, or during a blood transfusion if there's something going on? I can't tell you because you need to give me more details. So each situation is unique and the details make the difference. So just saying somebody has chest pain doesn't give me anything to go by, right? So what I'm gonna do is I'm gonna show you 2 different examples for each one of these, and one will be yes, you call a rapid response, and the other one you don't call a rapid response, and you'll see why just saying symptoms or diagnosis will not determine whether you call a rapid response or not. So example number 1 for chest pain. You walk into a patient's room, he's coming in for cholecystitis, a young patient, and he tells you while you're in there, oh, I'm having a little bit of chest pain. So just because he said, I'm having chest pain, do you call rapid response right away? No. Let's go through the steps. First, take a breath. I added that in there because a lot of the times we like to just start go, 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 go. And you need to take a breath first because you need that oxygen in your brain so you can start thinking, okay? Because a lot of the times with me, if something's going on, I just want to do things right away, but I have to remind myself to breathe and think before you jump to conclusions. So in this situation, you took a breath, then you're going to assess the patient. Just looking at the patient, he looks stable, but just looking stable isn't enough. So what are you going to do? Okay? So if somebody's complaining of chest pain, you can get their vital signs. His vital signs were stable. So what's next? You can grab an EKG machine. So it depends on your unit, but with mine, we don't need to call a doctor for an order for an EKG. If somebody's complaining of chest pain, you can just grab it, do it, and then you can call the doctor to let them know what the results are afterwards. Okay? So let's say his EKG showed normal sinus rhythm, and then you ask him some questions. Okay, well, what makes this pain better or worse? Does something make it better? Stuff like that, all the pain questions. And the patient's like, well, it seems like every time I eat something, my chest pain gets worse. So you're like, okay, maybe it's not really cardiac, but don't assume. So what are you gonna do next? You're gonna review. So if you review his history, yes, he's coming for cholecystitis, and he also has history of GERD. And what I like to do is also review your arsenal. I like to call it review your arsenal. So like your medrec. So it turns out he has Tums, PRN for GI upset, and morphine, PRN for pain. So then you go to D. That's when you decide what to do. So am I gonna call rapid response for this guy after I did my assessment and reviewed all his stuff? At this moment, no. So I decide that I'm gonna give the morphine and the Tums and to call the doctor to let him know anyways of his chest pain and what I did. So I'll tell the doctor, hey doctor, I'm calling for this patient who's coming for cholecystitis with history of GERD. He was complaining of some chest pain, which is worse when he eats. So I did do his vitals, which were stable, along with an EKG that showed normal sinus rhythm. I did give him Tums and morphine, and after that he reported relief right away and his pain decreased all the way to a 1. I just wanted to let you know if you wanted to do anything else. So the doctor might decide he wants to do troponin or a chest x-ray, or maybe not order anything because he's thinking this is more related to his GI issues. But you still have to call the doctor to let them know that he did complain of chest pain. This is what you did. And so I'm going to give you another example of a patient that's complaining of chest pain. So you walk into a different room, a young girl saying she has chest pain. But when you look at her, she's very symptomatic. She's diaphoretic, short of breath. So what do you do next? First, well, you take a breath. Then you think, okay, let me assess her. She doesn't look too good, but let me get the vital signs. It looks like her blood pressure dropped to 70/53 and heart rate was showing in the 160s. So you did an EKG and it looks like she's having SVT. So in that moment, before I even review, well, actually I'm reviewing everything, like the vital signs. So that's when I decide she looks like she could crash if I don't do anything. Then in this situation, I will call rapid response, right? So as you can see, both patients complained of chest pain, but they presented very differently with different vital signs, different EKGs, and depending on what the details are, I chose not to call rapid for one and did choose to call rapid for this one, okay? Next is shortness of breath. So let me give you a first example. The first one is a patient who's coming in for a COPD exacerbation, and you walk into the room and he says, I feel short of breath. But when you look at him, he doesn't look any different than when you initially did your assessment. So with COPD patients, most of the time they do get short of breath, okay? So you took a deep breath, you assessed the patient, vital signs are good. They actually just did a blood gas right there and it was okay. And then you're gonna review what the patient has. So it looks like the patient has PRN duonems. So you end up giving him the duoneb treatment, or RT does, and then you decide that he's okay in this moment and he's not unstable, that you don't have to call a rapid response. Example number 2. You have a patient and they just finished doing a thoracentesis, okay? And right after, he starts saying, oh man, I feel short of breath. And then you look at him and then he starts getting more tachypnic, and then he holds on to the right side of his chest where they did the thoracentesis, and you're monitoring him and you notice that the oxygen starts dropping quickly. So in this moment, call rapid response right away because the patient could have a pneumothorax, and this is an emergent situation because you don't want him to go downhill. So for that example, I already saw that his oxygen was dropping and he was getting tachypnic. So I'm not gonna wait to, let me check your blood pressure real quick, and he's already like can't breathe, you know? So depending on what the symptom is, decide quickly, like do your assessment quickly and see what the patient needs. And if it's something like this, that their breathing is deteriorating, then call rapid response. You don't have to wait to like, oh, let me get your blood pressure before I call rapid response. In this situation, just call it when you see that he's gone downhill, okay? So the next one is seizure. So if your patient is coming in with a diagnosis of seizure, they already have history of seizure in the past, they take seizure medications, and they have PRN, let's say Ativan, PRN like Q1 for seizures, then you're not gonna call a rapid in that moment. But let me go into detail. So let's say you walk in, the patient starts having a seizure. So you go right away, grab the Ativan, and give it to the patient. So that's what you did. You took a breath, you assess that they're having a seizure, and let's say they're connected to the SpO2 probe and you see they're setting 100%. So then you review what you had and you have the Ativan on board. So you decide to grab that right away so you can give it. And then after you gave it, the patient was good. So in that moment, I didn't call a rapid response for that seizure. But let's say you have a patient who's coming in for something completely different, and then you walk in the room and it looks like they're having an active seizure. They have nothing on board PRN for a seizure because they had no history of this before and they didn't know they were going to have a seizure. And you notice that the oxygen is dropping. And then you tried to call the doctor for a second, they didn't answer you, and you need order stat, right? So you're not gonna wait a whole 5 minutes if the seizure lasts 5 minutes, status epilepticus. At that moment, I would call a rapid. And some people might argue with me on this because I know it's a debate. They're like, why are you calling a rapid for a seizure? Well, if this is something new and you don't have any medication on board, this is a change in condition for a patient. And you can't just wait, because let's say it does last up to 5 minutes, then that's dangerous, right? So in that moment, then I would call a rapid response. But can you see the difference between the two different situations, even though they're both seizures? The next is a blood transfusion. So let's say you're giving a blood transfusion and all the vitals are stable, the patient's not short of breath or anything, and then they report like, I'm feeling not too itchy, but it feels kind of itchy. And you're like, kind of itchy? And you're like, yeah, a little bit. So then you still want to think that could be a blood transfusion reaction, right? So what do? You stop the transfusion, call the doctor, and let them know. Then they might tell you to give, saline and Benadryl and stuff like that. But in this moment, the patient is stable, and let's say after you gave that Benadryl and the saline, the patient was fine. So for that example, the patient was stable and the only symptom really was just slight itching. But you still want to continue to monitor the patient because that little itching could turn into something worse when you will actually need to call rapid response. So let me give you another example. This is actually a story of my very first rapid response as a new nurse working night shift. So this patient was coming in just to receive 2 units of FFP. They were trying to get his INR down because he was on Coumadin and he needed to have surgery. So very nice patient, and first unit of FFP went in fine, no issues. And then the second unit, I started it and I told that patient, I'll be back later to check on you, call me if you have any issues, okay? So I just left the patient's room. I walked around and then something told me, oh, let me just check on him. I don't know why, just in case, because I wasn't gonna check until later. But he didn't call or anything. But I just remember walking into the room. It was dark. And then I heard, does my face look swollen to you? And I was like, what? I was like, does my face look swollen to you? So I turned on the light and my patient's face was blown up. Like that pink character from Dragon Ball Z. That's how blown up it was. And in that moment, deep inside, I was freaking out. But I called rapid response right away. I didn't even take a breath. I didn't even follow this because my thinking was, he's swelling up. Next thing you know, he's not going to be able to breathe, and then they're going to have a real problem here. So the whole rapid response happened. I was so nervous, and at the end of it, I thought I did so bad for some reason, And then my charge nurse took me to the side and she was like, you did so great. You know, you were so calm, cool, and collected, and you spoke to the doctor and gave them all the information that you knew about the patient. And I'm so proud of you. And I was like, really? I was like, thank you. Because it's funny, you know, as a new nurse, you think you're not doing as well as you think you are. And then someone tells you that you do a good job, and that makes you feel good, you know. Oh, and by the way, of course, when I saw his face and his tongue swollen up, I did stop the transfusion. Of course, don't forget to do that. If your patient's having a possible blood transfusion reaction, the first step is always to stop it. Because I think that's the other thing. If you're not thinking and you're not breathing, you might forget to stop it, and that's what's causing the issue. So that's very important, okay? So you always want to try to assess before you jump to conclusions, but also don't assume nothing is wrong, then your patient codes later. So in your nursing lifetime, at one point, you might call rapid response and somebody will judge you for it and say you shouldn't have called rapid response. It happened to me. I called a rapid response for something that I thought was very justifiable. I still think it was very justifiable. I'm not gonna give the details, but people will still laugh. They're like, oh, why did you call rapid for that? But from my assessment and from what I reviewed, I thought that it was correct. And don't let other people laughing at you for calling something make you not want to call rapid responses in the future, because it's better to call it and let it be okay, like nothing's really an issue, rather than you don't call it and then your patient codes later. So now that you know when to call, what do you do once you do call that rapid response? So if you're the main nurse for that patient, you really want to try to stay in that room, because when the rapid response team gets there, they're going to be trying to look for you to get more information. So let's have an example. Let's say you walk into a room, the patient was unresponsive, but looks like they're breathing, and they do have a pulse. You try to sternum rub them, and you keep trying to wake them up, and they just won't wake up. So in that moment, I would call rapid response, and as people are coming in, normally it's your coworkers in your floor that comes in first before the rapid response team, at least for a smaller hospital. So what do? When they're coming in, you start delegating. Hey, could you please grab me the AccuCheck, grab the crash cart while I get the vitals here. And then as they're doing that for you, the rapid response team comes in, and then the provider will start asking you questions. So you want to have your brain available, and a lot of the times my paper is my brain because it has a lot of information about the patient there. The first thing they'll ask is, who's the nurse? And you're in the corner like, me. And then they'll say, what's going on? So then you provide them with information. So let's say, oh, well, this patient is a 65-year-old male coming in for a hip fracture. 30 minutes ago, I was in the room and the patient was alert and oriented ×4, but I did give him like 2 milligrams of morphine at that time. I stayed in the room for a couple minutes and the patient was stable at that time, and then I went to leave, but when I came back, he was unresponsive. So then you could suggest maybe this could be related to the morphine, and then maybe they'll say, okay, let's just give Narcan to see if that's the issue, and then you go from there. And like I said, it really depends on your hospital, because sometimes the rapid response team will have everybody in there with their assigned role already. But if you're in a smaller hospital, there might just be one ICU nurse who comes in and a provider, so everyone else who jumps into the room will assume a role, you know, because you won't have as many staff members as a gigantic hospital would, you know. So how are you going to handle it? Well, if this is your first rapid response, and if you're watching this video, you're probably interested because you never had a rapid response before and you want to figure out how to deal with it when it does happen to you, right? So the main thing, like I said, is try to, breathe, assess, review, and decide. And again, each situation is different. So if a patient looks stable, you might have more time to do the vitals and all that. But if they're clearly going downhill, you want to call rapid response right away. But it's a lot of adrenaline, you know, especially if it's your first time. And let's say you're in a med-surg unit and you have 7 patients. So while you're dealing with that, you have 3 other patients who are calling you. So it's kind of like overload, you know. And people always say you need time after the rapid response to debrief, but sometimes they don't do that. But you need to take time, because if you're stressed, you're not going to be able to handle your other patients. So sometimes if I'm really stressed out, let's say the time when I had a code and a rapid at the same time, and after everything was done, I'm just like, I need to take a water break. So, you know, I splashed some water on my face in the bathroom, took a sip of water, took a bite of something, because I need energy to continue my day, because it was a lot, you know? So remember to take care of yourself so you can take care of your patients. I say that all the time to people, but sometimes I forget that. So my main tip is, while everything's going on and the chaos is happening, family members are in the room, providers in the room, everybody's asking you a million questions, people are shouting, the best thing is really to try to breathe so that you can think about what to do, so you can be collected and inform the provider what needs to be informed for your patient. Thank you for watching my video, and I will see you on the next episode.